Hello, I'm Professor Susanna Banerjee. I'm a consultant medical oncologist at the Royal Marsden NHS Foundation Trust and Institute of Cancer Research in London, UK. Welcome to our fourth episode in our podcast series titled To Combine or Not to Combine Chemotherapy and Immunotherapy. Is that the question in endometrial cancer? Joining me today is Professor Domenica Lorusso from Rome, Italy. Welcome.
My pleasure to be here. Thank you.
So, one of the key questions that we have in clinic is about combination therapies or monotherapy in endometrial carcinoma. And the combinations may well be with chemotherapy in the first line setting, but also non chemotherapy targeted agents combined with immunotherapy. And many of us around the world are having access to immunotherapy now, and of course, this will increase hopefully as we have more clinical trials. So I really wanted to ask your opinion on situations that we face in clinic. So, for example, if we have a patient with recurrent endometrial carcinoma who's had first line platinum based chemotherapy and had recurrence 12 months later, what are the things that you would want to know in terms of decision making, and what are the options that you would see in this setting?
Oh, thank you, Susie. This is what happens really in clinical practice every day. So, the first information I need to know is what is the molecular profile of my patient. We have anticipated the molecular profiling of the tumor at diagnosis, but still we see patients with recurrent disease for which we need the molecular information. So, what is happening now? We need to know if the patient is DMMR, so present the instability of microsatellite, or PMMR without instability. And this is the first discrimination between the patient that we treat every day, because what we know is that if the patient is DMMR, this patient has the potentiality to respond very well to immunotherapy single agent. Two trial, Keynote 158 and Garnet trial, using Pembro and dostarlimab respectively, demonstrate that the overall response rate in a DMMR patient with endometrial cancer recurring after platinum-based chemotherapy is around 50%, which is really good. This means that one out of two patients respond to immunotherapy single agent. And if the patient respond, the response is quite long. About 80% of patient is still in response after 2 years of treatment. And also the toxicity profile of immunotherapy single agent is very good. We perform our learning curve. Now we are able to manage immunotherapy related toxicity, which are mainly thyroid dysfunction in most of our patients, and mainly grade 1, 2. So now we are able to manage this kind of toxicity, but the response is very high and very long. For sure, Susie, it's evident. 50% of patients respond, but 50% of patients unfortunately does not respond. And it's a really tricky for us, because we are not able to predict who will be the patient who respond and who will be the patient that does not respond. And this is probably the challenge that of the clinical research for the coming years.
So, in terms of lenvatinib and pembrolizumab, how do you, in practice, make decisions for your patients with regards to the combination of lenvatinib versus other options, including standard of care chemotherapy? For some patients, this may be, a valid decision. So I'd be interested in your thoughts about, for example, balancing comorbidities or toxicities. Can you expand on that?
Oh, that's a very, very difficult question, Susie. So, the keynote 775 compared the pembrolizumab versus physician choice chemotherapy between weekly paclitaxel or doxorubicin in recurrent endometrial cancer patients who have received one prior line or two prior line of platinum, no more. And the trial clearly reported a significant benefit in progression free survival, about 4 months increase in progression free survival, but also in overall survival, about 8 months increase in overall survival when we provide pembrolizumab to our patient with respect to chemo. The trial has a stratification criteria represented by the status of microsatellite instability, but a benefit was reported either in pMMR and dMMR patients. So potentially in Europe, when I see a patient with microsatellite instability, I can use both. I can use immunotherapy single agent, but I can use also the combination of pembrolizumab. Unfortunately, we have not biological predictor guiding our choice of single agent or combo. So in this moment, the only criteria to choose is the toxicity and the patient we are treating. Endometrial cancer patients are generally older, they have several comorbidities. They have hypertension, cardiopathy, diabetes. They are obese. So it's more fragile with respect to ovarian cancer patient or cervical cancer patient. And I think this should be considered because pembrolizumab provide is a combo. So by definition, provide additional toxicity to pembro or dostarlimab single agent. Consider that in the registrative trial, where by definition we enroll the best patient, we treat good performance status, comorbidities under control, even in the registrative trial, 66% of patients reduced the dose of lenvatinib and 33% of them discontinued the treatment because of toxicity. This means that we have to properly select the patient to offer pembrolizumab. For sure, we learned how to manage the toxicity of pembrolizumab. Most of them occur during the first 9 weeks of treatment. We anticipate some toxicity. We prescribe antihypertensive agent before hypertension occur. There are some preventive strategies. We educate the patient. The toxicity is not unmanageable, but if I have a drug with a very limited amount of toxicity that provide 50% overall response rate in the dMMR population, and I have a combo that in a very brutal indirect trial comparison provided 40% overall response rate with an additional toxicity, my first choice in this patient is to offer immunotherapy single agent in most of them.
So I would agree with you. In practice for DMMR patients in this setting, I've been using monotherapy for the reasons that you have explained. I think it would be really interesting to see where we go in the future. For example, if those patients that receive monotherapy in the recurrent setting post platinum, how to treat next. And I wonder whether potentially, obviously, in the trial setting, then looking at lenvatinib, perhaps re-challenge with IO, PD-1, PD-L1 inhibitors would be an interesting avenue to approach and to gain then further benefit. But we just don't know those answers yet. So, and in terms of beyond immunotherapy, the the future is ADCs, I think, and we commented on that in an earlier episode. So I'd refer our participants to episode 3. I want to sort of bring you back earlier on into the patient pathway. The case I provided as an example, is what we face now in clinical practice, which is IO options post platinum. But with the increased use, hopefully, in the first line setting, thinking about combinations or monotherapy for immunotherapy, one of my questions really is, what is the efficacy contribution of chemotherapy when combined with immunotherapy, for example, in the DMMR, MSI high endometrial cancer population? Um, Talking about toxicities, as you've outlined, I think that this is one of the questions that we need to address. And I just want to hear some of your comments or feelings at this stage about that.
Absolutely, Susie. This is one of the questions that we have to address in the future. When you look at the curves of Ruby or GYO18, the curves start separating at the end of chemo. So the question of what is the additional contribution of chemo, it's a very important question. You know, we are running two randomized phase 3 trial comparing immuno versus chemotherapy in the setting of endometrial cancer patient with advanced or recurrent disease, chemo naive for treatment for advanced or recurrent disease. And this trial will provide for the first time the evidence if immuno is as good as chemotherapy or probably superior to chemotherapy. Unfortunately, this trial actually is not exactly the most attractive control arm, because the control arm is only represented by chemo, and you know that after GYO18 and Ruby, the control arm should be better represented by chemo plus immuno. But unfortunately, when we designed the trial several years ago, we could not be so visionary to understand where we'll be 5 years later. And this is the reason why the control arm is not appropriate. But we will see also in this scenario at ESGO in few months the results of the LEAP 001 trial that compare pembrolizumab versus carboplatin paclitaxel in the setting of chemo naive advanced or recurrent endometrial cancer. So probably we will have a combo instead of chemo in patient in the intention to treat population. I mean, not only DMMR, but specifically PMMR patients. So the future is very interesting, because I'm sure that we will have more and more patients that will require chemo naive strategy and chemo free strategies. And I expected that immunotherapy single agent for the DMMR population and pembrolizumab for the PMMR population, if the trial are positive for sure, will represent a valuable alternative to chemo.
Such an exciting time, isn't it? The standards of care are being pushed and the boundaries are being pushed and changing in such a short time frame, in the first line setting from 2023. And you've just highlighted that there'll be more results in 2024 that could potentially be practice changing. So our key duty really is, with these trials, about access to new approaches, and also, as you highlighted earlier, the management of toxicities in clinical practice. For many of our patients with endometrial cancer, they may have comorbidities that are really important to take into consideration, like diabetes, hypertension, cardiac risk. And we really need to treat patients in a multidisciplinary way. And I think what's so exciting is that we actually have options that we can tailor to our patients, not only based on molecular status, but also due to clinical factors and risk of toxicities in practice. But I share your enthusiasm. I think we're at the time where we are increasing survival, have opportunities to increase survival and increase treatment options beyond chemotherapy, which we've had for decades. So it's a really exciting area. I think one of the main messages that you've alluded to is the need for molecular status of our patients in clinical practice, this is critical for us to make decisions for our patients. So thank you, Keta. Thank you for participating, everyone, in this activity. Please continue on to answer the questions that follow and complete the evaluation.